All right, let's go ahead and talk about altered mental status, beginning with some terminology. It's important to note that altered mental status is not a diagnosis in and of itself. It is always due to an underlying disease process. Patients move from the continuum of normal on off to coma, and I think it's important to talk about some of the terminology here. A patient who is obtunded or stuporous is not totally asleep, but they do demonstrate greatly diminished responses to external stimuli. Lethargic patients aren't just lounging around on the couch. They have depressed consciousness that's resembling a deep sleep from which they can be aroused, but into which they immediately return. A coma does not just occur in movies where a patient dramatically wakes up, but it is a transient state of complete unawareness and unresponsiveness. Irritability is the state of being abnormally responsive to light stimuli. Think the child with Kawasaki who just is fussy, and no matter what, they're difficult to calm down. Delirium is an acute confusional state with confusion, disordered speech, and hallucinations. Now, certainly the differential diagnosis of altered mental status is very broad. If you're a mnemonic person, consider AEIOU TIPS. Alcohol, encephalopathy, electrolytes, insulin intussusception, overdose, uremia, trauma, infection, psychiatric, seizure, shock, stroke. Yes, all of these things can cause altered mental status, but I think it's helpful to break them down into major overreaching categories. Primary CNS disorders focally affect the brain by generally exerting external pressure. So it's like a bleed or a mass or something that causes elevated ICP. And this could be due to edema or altered cerebral blood flow. Systemic abnormalities alter neural activity through decreased availability of important stuff like blood flow, oxygen, glucose. They alter intracellular metabolism, temperature irregularities, exogenous or extraneous toxins like ingestions or stuff that comes from the body from liver and kidney failure or other conditions like lupus or Wilson's. Certainly, it's impossible to get to all of these in a brief overview. Importantly, hypoxia. If a patient is hypoxic and they have altered mental status, you're going to want to fix that. No surprise there. Hypercapnia causes cerebral vasodilation and increased cerebral blood flow. Hypocapnia causes vasoconstriction in the cerebral vessels and thus decreased cerebral blood flow. In periods of hypoxia, the body can increase cerebral blood flow up to twofold. But note that the O2 sat doesn't necessarily reflect cerebral oxygen delivery, and thus patients that are mildly hypoxic can have normal SATs, but they will have some difficulties with complex tasks and short-term memory. Cognitive and motor disturbances occur with moderate symptoms. Severe symptoms, you'll lose consciousness, have a seizure, lose brainstem responses, and have brain death, all of which I think we'd agree are bad. The brain also likes glucose. So autonomic systems start at glucoses of about 40 to 70, though certainly these numbers may vary based on the patient's age. This includes sweating, weakness, tachycardia, tremor, nervousness, and hunger, obviously. Neuroglycopenia occurs when the glucose levels are much lower. This is lethargy, irritability, confusion, altered and odd behavior, seizure, coma, very bad things. As you'd expect, the brain functions differently when it gets cold. So in hypothermic patients that have mild coldness, 32 to 35 centigrade, you'll just mostly see peripheral signs on the body and preserved consciousness. It's not until you get to really 30 degrees or thereabouts that you'll see slurred speech, clumsiness, agitation, impaired thinking. Confusion and lethargy really manifest significantly as the core body temperature drops. In severe hypothermia, these patients aren't even shivering anymore. They have muscle rigidity and flushed skin. They're frozen stiff. You progress from stupor, then coma, and then fixed and dilated pupils. So patients can look dead. They just really have no neuromotor activity. So those pupils may work again once they get warmed up. Hyperthermic kids with heat exposure and elevated body temperature greater than 104 and CNS abnormalities should be treated as heat stroke beyond the scope of this brief talk. These CNS symptoms include impaired judgment, inappropriate behavior, out-and-out delirium, hallucinations, ataxia, dysarthria, or even coma. Infections globally cause CNS dysfunction. Meningitis, encephalitis, and focal infections like empyemas and abscesses can all do this. Antibiotics and antivirals obviously are the linchpin of treatment. Interestingly, mycoplasma, chlamydia pneumoniae, and EBV can cause severe impairment of mental status with or without meningoencephalitis. Hard to test for, but worth thinking about. And it's true, many drugs can cause altered mental status. Go ahead and write these down. I'll wait for you. But really, there are only a few toxindromes that you really need to remember for board's purposes and for general clinical practice. Remember, these aren't diagnosed using a urine drug screen. More on that a little bit later. These are toxindromes that you can encounter and readily recognize both clinically and on the boards. If you'd like to, you can pause the slide and take a look at them in detail. I won't go over them in the interest of brevity. And finally, psychiatric causes. Yes, a patient acting crazy may have a psychiatric diagnosis, but unless there's a past history of this exact same behavior, it's a dangerous assumption to go the direction of psych. The differential is certainly broad, and note that medical was more common than psych in the ED. If unsure at all, you got to do a workup. Diagnoses include schizophrenia, mood disorder, severe depression with psychosis or hallucinations, brief psychotic disorder. All of these can cause altered mental status. Acute onset psychosis, there's disruption in thinking, and this is accompanied by delusions or hallucinations. Now, delusions, they're false fixed beliefs that can't be resolved through logical argument. Hallucinations, these are false perceptions that don't have a basis in external stimuli. Other patients may feign unconsciousness or be catatonic. Now, the catatonic patients generally preserve their ability to maintain posture. Quote-unquote fakers usually, not always, avoid hitting their face with a falling arm that you drop, resist eyelid opening, raise their heart rate to auditory or painful stimuli. They do have intact DTRs, oculovestibular, and oculocephalic reflexes, so you don't want to do those latter ones if you're concerned about trauma, but that in addition to taking a firm finger to their sternum or to the jugulo-digastric notch or other noxious stimuli may allow these patients to wake up. Now, brief hallucinations can occur in normal situations, like falling asleep and waking, bereavement, sleep deprivation, or caffeine, the latter two of which may be common in the medical professions. And when differentiating so-called organic and psychiatric psychosis, generally the organic psychosis is more likely to be acute. You're going to have some sort of autonomic signs or abnormal vital signs. Orientation and recent memory will probably be impaired, and visual hallucinations as opposed to auditory hallucinations will occur. And as always, it's important to consider the life-threatening causes of altered mental status. These include epidural hematoma, cerebral edema, brain cancer, infarction, shunt malfunction, meningoencephalitis, toxic ingestions, hypotension, hypoxia, and sepsis. Always think about these when you have a very sick patient with altered mental status. Now, when it comes to the management, it's first important to consider whether or not to take the patient to the trauma bay. Now, in my institution, this is called the STS, the shock trauma suite. It may be called the resuscitation area, the trauma bay, the big room, whatever you want to call it. In general, if there's a problem with the ABCs, the airway, breathing, or circulation, does the patient need meds or fluids now? Do they meet any of the following criteria? Are they intubated, apneic, they need CPR, they have severe respiratory distress, low oxygen saturations, acute mental status changes, are they unresponsive? Get them in the big room. Your job is really to do an immediate assessment of these sick patients. This is a rapid cardiopulmonary assessment with a secondary survey with attention to the pupils, the GCS, mental status, and signs of trauma. So therefore, I present a general approach to the assessment and management of altered mental status. It begins, of course, with the ABCs. This includes airway, breathing, circulation, and basically disability and environment as well. Anybody who looks abnormal and has abnormal vital signs should get an IV. Pay attention to oxygen, glucose. If you think it's an opiate, give them Narcan and get some screening labs if you're able to. Then you can proceed to studies like a head CT and lumbar puncture. But again, it all starts with the ABCs. And your assessment really of the ABCs is not just airway patent. It includes interventions needed to address big problems. So the airway, you got to make sure that this patient can maintain the patency of their airway, and this may deteriorate over time. If they're going to be intubated and have altered mental status, presume a full belly and use rapid sequence intubation. It will increase your chances of success and blunt those responses that plastic introduces when it goes into the airway. Breathing, well, ventilation may be impaired by declining respiratory drive or muscle dysfunction. You want to keep the SATs above 95% with supplemental O2. Use N-tidal carbon dioxide, much more sensitive in picking up early changes in respiratory function, and intubate those who can't sustain adequate oxygenation or ventilation. For circulation, continuous EKG monitoring is obviously very important. You got to assess for perfusion and identify shock. Get an IV for any patient with abnormal vital signs. Disability, well, GCS. Repeat it as the patient changes. Going from a GCS of 15 down to 13 is a very important change that suggests interventions. And do a pupil exam, because we know the pupil response is the most direct window to the brain. Conditions affecting the brain diffusely may spare the pupils, except for opiates and their effects on the mu receptors. And then when it comes to labs, ask yourself the two following questions. Will the lab alter the approach to treatment? And will it return on time to affect therapy positively? Sure, you can get quantitative serum levels like digoxin and salicylate, acetaminophen, AEDs. You can get carbon monoxide. If you suspect poisoning with one of those agents, great. But otherwise, these labs don't alter your immediate management. What labs make sense? Well, blood gas or an iStat, plus or minus an AccuCheck. A renal panel, which is electrolytes or a Chem7. Osmolality. Tox screening, maybe acetaminophen, salicylate, ethanol in a urine drug screen. And for the 50% of the population that is capable of being pregnant, a beta-HCG. Now, acetaminophen levels, ingestions of many kinds are usually symptomatic by 4 to 6 hours. One of the most important ones that isn't is acetaminophen. Now, there is some research that looked at whether or not these are likely to be valuable. So back in 96, Sporer looked at 1,820 patients with suicidal ideation or altered mental status with suspected ingestion. 0.3% had toxic acetaminophen levels not suggested by history, but none of those required an acetylcysteine. Another review back in 95, again, suspected acetaminophen poisoning had elevated but non-toxic levels. So in the absence of history, acetaminophen ingestions are rare. You should still probably get one due to the impending harm. If it's elevated and you're not sure of the time, repeat it at about 4 hours, as long as it's not above that treatment line. If so, go ahead and treat. Salicylate levels, probably less useful, still valuable to obtain in the unknown ingestion with AMS, knowing that you could have a mixed acidosis from metabolic respiratory causes. The Doan nomogram, which you may have seen, no longer routinely used. Greater than 90 to 100 milligrams per deciliter is a level that's usually associated with severe toxicity, but you may need multiple determinations in massive ingestions or in those sustained release tablets. Main symptoms that you'll see: vomiting, hyperpnea, tinnitus, lethargy, that mixed respiratory alkalosis and metabolic acidosis. Bad cases: coma, seizures, hypoglycemia, hyperthermia, pulmonary edema. Obviously conditions you don't want to miss. In the patient that's naive, ethanol will follow zero-order kinetics. The rate varies, but naive drinkers, it's 10 milligrams per deciliter per hour. So if you've got a level of 210, it could take up to 21 hours to metabolize all of that. There's really a rough correlation between level and symptoms. Certainly habitual drinkers can have a level that's relatively high and they can be quote-unquote functional. A level less than 300 in a comatose patient should prompt a search for another cause, though. And then the urine drug screen. You can see metabolites of certain agents for 2 to 3 days. There are multiple types available. The blood, maybe 6 to 12 hours, so certainly shorter. And really the question that comes up is does a urine drug screen or tox screen affect the management of a patient who has taken an overdose? Even if it's positive, according to the listed studies, which you're welcome to look up, it rarely alters management. Go ahead and order one. It may be important for diagnostics or additional follow-up, but don't base your management on it. Recognize those toxindromes and address them accordingly. EKG is another good screening test. It can show heart block with DIG or other cardioactive drugs. TCA is one of the most quote-unquote testable overdoses that you may see. It's got QRS widening, rightward shift to the terminal 40 milliseconds of the QRS complex, the terminal R wave and AVR. Here's a good example of that on an EKG. You can see the QRS being wide, greater than 100 milliseconds, and then that terminal R wave greater than 3 millimeters, and the R to S ratio being greater than 0.7. So learn to recognize these. It'll probably show up on a test. And then Narcan. It's the mu opioid receptor competitive antagonist. If you think it's an opiate, give it. It may help in cases of clonidine, probably not. Certainly, though, the multiple ways that Narcan can be given can be helpful. But remember, Narcan doesn't save lives. It just prevents procedures like intubation. There are other antidotes. Don't give flumazenil for a benzo overdose. That can precipitate seizures. Physostigmine may transiently improve mental status and an anticholinergic ingestion. Definitely don't use that if you've got a wide QRS complex because it can make things really bad if it's a TCA. And then diphenhydramine if you've got dystonia from a phenothiazine. The list of these antidotes is quite large and beyond the scope of this talk. Do an LP if you suspect meningitis, encephalitis, subarachnoid hemorrhage, but you got to ask yourself, is the patient stable enough? And if they have altered mental status, is sedation necessary and safe to do in order to get the LP? A reasonable question to ask. Head CT, valuable in any acute coma of unknown etiology. This includes elevated ICP, trauma, CSF shunts, focal neurofindings, the unsupervised child. Give antibiotics to any kid you think has meningoencephalitis, including ceftriaxone, vanc, acyclovir. Try to delay it until after the LP. Physical restraints, well, they need regular reassessments and appropriate documentation. Chemical restraints, there are multiple meds. PO can have similar onset to IM. Try to consider other interventions first. The list of these is long. I wouldn't worry about memorizing it for this talk, but you can certainly pause the slide and take a look. So some take-home points. Remember, altered mental status is usually caused by an underlying disease process. Your workflow, ABCs, IV, glucose plus labs, CT, and LP. Consider antidotes like Narcan when applicable. And remember, even with a past history of mental health illness, acute onset psychosis is more commonly associated with an underlying medical cause. So don't just assume that it's psych without doing an appropriately thorough evaluation and workup.